Okay, welcome to the next module. This is Dr. K or Dr. Greg speaking, and we're going to talk about upper and lower respiratory disorders. So, at the beginning of this module, I'm going to spend some time briefly just talking about the disorders, and then we're going to go into them in more depth later on. Okay, so if you would rather just go to the in-depth topic, then skip the slides that have the list of topics on them. But I think they're worthwhile listening to because they just give you a general overview and a feel for the different conditions. Okay, so let's get started. Now this is chapters 20 to 26, so there's quite a lot of information. I'm trying to keep these to 3.5 to 4 hours, so hopefully this one stays at that length of time. Okay, so here's the first slide on some topics that we're going to discuss. Some of these we're not going to go into as much as other topics. Okay, so let's start, and it's good to just recognize the different diagnoses and the different terms and what they mean. Okay, so let's start at the top. What's rhinitis? Rhinitis is just another term for inflammation of the nasal mucosa. Okay, so what can it be from? Well, typically it's from either a viral infection or it can be from allergic conditions that when the person inhales the pollen or the allergen, they have congestion of the nasal mucosa, and typically they'll have a runny nose, sneezing, and sometimes rhinitis, whether it's from a virus or from an allergy, can block the pores or what are called the ostia, the holes that allow the sinuses to drain. So you can get a secondary sinusitis because of all the inflammation that's taking place within the nose. Okay. So if it's an infectious rhinitis, typically from a virus, well, it's really just symptomatic treatment, right? We can use short-term decongestants such as phenylephrine. They're typically over-the-counter, and they just run their course, right? They're not typically a bacterial infection. Okay. All right, what's sinusitis? Well, sinusitis is inflammation and infection of the sinuses of the face. So we have frontal sinuses, which are above your eyes. We have maxillary sinuses, which are basically in your cheeks. We have ethmoid sinuses, which are basically behind your upper nose. And these sinuses can get infected, right? And most of them we know now are, again, from viruses. You can rarely develop a bacterial infection of the sinuses. And if it's a bacterial sinusitis, then we'll treat those with antibiotics. Okay. What are the symptoms of a sinusitis? It's usually localized pain over the sinus that's infected. So it might be facial pain or pain over your eye, your eyebrow area, purulent nasal discharge, sometimes bloody nasal discharge. You often have nasal congestion with it. Okay. Laryngitis is inflammation and sometimes infection of the vocal cords. So if it's an infection of the vocal cords, it's typically viral. Okay. So what can we do for this? Well, typically we just tell the people to rest their voice, increase fluid intake to keep the vocal cords lubricated, and most of the time it just settles by itself. Okay. So again, laryngitis can be a viral laryngitis, or it can be from overuse of the voice, right, where you've irritated the vocal cords. And what do you do for that? Voice rest, right? Sometimes we'll use anti-inflammatories for any of these conditions, whether it's rhinitis, sinusitis, or laryngitis. Okay. What's pneumonia? So pneumonia is an infection of the lung. And more specifically, it's an infection of the alveoli of the lung. So the alveoli fill with pus and fluid, and you can have bacterial pneumonias, you can have viral pneumonias, those two are by far the most common. You can have fungal pneumonias of the lung, which are much less common. They would typically be in immunocompromised patients more often. And we'll get into that in more detail. Influenza, a viral infection, right? And we'll talk about influenza in more detail. So it's a respiratory condition where you develop a viral infection, and typically it's like a really, really, really bad cold. So cough, fevers, but now you have sore muscles, myalgias, you have aches all over your body. You've lost your appetite, you feel weak. And a complication of influenza, and one of the deadly complications, is developing a influenza pneumonia. Okay? What's ARDS? Acute respiratory distress syndrome. So this condition is typically caused by any severe illness that's occurring in the body. Okay, so it doesn't necessarily have to start in the lungs. And what happens is the blood vessels within the lungs become leaky and vasodilated, and they leak fluid into the interstitial space all around the alveoli, and that leads to very stiff lungs because they're filled with fluid, right? So it makes it hard for the person to breathe. They can't expand their lungs because they're so stiff and filled with fluid. So some patients with ARDS, they can't maintain their oxygen levels in their blood, and this can lead to the need for intubation and ventilation. Okay, let me give you an example. Someone develops severe pancreatitis. Okay, well, with severe pancreatitis, you can have diffuse inflammation throughout the body. That causes the blood vessels in the lungs to be leaky and lead to ARDS. Okay, another example, burns. Somebody has a severe burn, which causes tremendous inflammation. The inflammation travels through the bloodstream, and in the lungs it causes vasodilation and leaky blood vessels, causing ARDS. So ARDS can be a complication of other diseases. Okay. Another example, someone's in a car accident and they have a massive force hit their chest, such as a steering wheel, because they weren't wearing a seatbelt. Well, they're going to get bruised lungs. We call that a pulmonary contusion. But they can also develop secondary ARDS because there's inflammation, and that can result in a lot of fluid leaking out of the pulmonary vessels, causing stiff lungs, ARDS. Okay. What's asthma? Asthma is a recurrent condition through life of airway bronchoconstriction and airway inflammation. And we'll talk much more about asthma. But remember those two components of asthma: bronchoconstriction, airway inflammation, causing excessive mucus production. And it's recurrent, meaning in between the episodes, the patient may be just fine with very little symptoms. Patients with asthma often need bronchodilators and anti-inflammatory medications to control their asthma so that they don't get frequent flare-ups. COPD, so chronic obstructive pulmonary disease, is a disease typically from smoking. That's the number one cause. And there's two components to it. There's chronic bronchitis, which is uh, damage to the bronchial tubes that leads to excessive mucus production. So they're coughing up phlegm chronically. That's the first part. The second part is emphysema, which is destruction and inflammation of the alveoli. Okay, and that's going to lead to decreased ability for oxygen to cross over the alveoli to the bloodstream, and also difficulty for CO2 to get into the alveoli to be exhaled. Okay, so think of COPD as those two conditions combined: chronic bronchitis and emphysema. What's tuberculosis? It's an infection of the lung typically. So pulmonary tuberculosis is the most common form of tuberculosis. It can also affect lymph nodes in the body. It can affect organs of the body. You can get tuberculosis of your kidneys, of your adrenal glands. Okay, but by far the most common is pulmonary tuberculosis, and it's caused by mycobacteria. Okay, and we'll talk much more about tuberculosis. Okay, what's Legionnaire's disease? This is a type of pneumonia, Legionnaire's pneumonia, and it's caused by a bacteria. Okay, so Legionella pneumonia is the bacteria that causes this disease, and typically people get it from soil or water. There's often outbreaks of Legionella, say in buildings where the air conditioners haven't been working well, and the water in the air conditioner is growing Legionella, and the fan of the air conditioner is throwing out the bacteria into the air that people inhale. Okay, so we often hear of outbreaks of Legionnaire's disease. So if I think of Legionnaire's disease, I typically think of inhaling the bacteria from some kind of water source that's contaminated, whether it's a shower, a hot tub, a ventilation system with air conditioning, anything where there's water that's vaporizing into the air. Okay, what's a pulmonary embolism? Well, a pulmonary embolism is a clot of blood that's typically traveled from a deep vein thrombosis in a leg or pelvic veins, broken off, traveled to the heart. Okay, it landed into the right atrium and then the right ventricle, and then got pumped to the pulmonary system through the pulmonary artery, and it lodged into a segment of a pulmonary artery or pulmonary vessel, causing blockage of that artery. Okay, so what's going to happen? Well, that part of the lung could die, okay, potentially because of loss of blood supply. That part of the lung is not going to receive any blood flow. Okay, so there's going to be, so a pulmonary embolus is a perfusion problem, lack of blood flow to a certain part of the lung. Okay, what symptoms do people usually develop with pulmonary embolism? They usually come in and say, I had the sudden onset of shortness of breath, I coughed up some blood maybe, and I have pleuritic chest pain. When I take a deep breath, my chest hurts in a certain area. Okay, so why is that the case? Well, every time you take a deep breath, you're stretching that pleura, and with a pulmonary embolism, you've blocked an artery to a segment of the lung, and that segment of the lung is touching the pleura, and it's inflamed now. So when you take a deep breath, you get pleuritic chest pain. Okay, so when we hear someone has pleuritic chest pain, we think of a pulmonary embolism to rule out. Okay, what's sarcoidosis? This is a strange condition. It's an inflammatory condition of the lung where you form what are called granulomas, which are just collections, basically lumps of inflammatory cells that we see on chest x-ray. Okay. Um, what are symptoms of sarcoidosis? Well, it can be anything, any respiratory type symptoms, because you're forming these inflammatory granulomas throughout the lungs. So you could have coughing, wheezing, shortness of breath, and we'll often diagnose it on a chest X-ray, a CAT scan, or sometimes even a lung biopsy. Okay, so it's not an infectious disorder. Rib fractures. Well, rib fractures are usually from trauma or a fall or a car accident or a motorcycle accident or falling off the roof. And it really just depends on how many ribs have been broken. If you have one rib fracture, um, with pain medication such as non-steroidal anti-inflammatories and maybe an opioid analgesic such as morphine, and we give someone a incentive spirometer to take nice deep breaths to avoid atelectasis of the lungs, they usually do fine. The ribs will heal in 4 to 6 weeks. If someone has multiple rib fractures, say 4 or 5 or 6 rib fractures on one side, say from a motorcycle accident, they may not be able to breathe on their own because there's severe pain. Okay, so they may require oxygenation, or an oxygen supply. They'll need significant analgesics, typically opioids, to control the pain. Sometimes patients with rib fractures will get a nerve block in their back to block the pain signals that are coming into the spinal cord from the fractures, so they can breathe better. Okay. A flailed chest. Well, we're still on rib fractures here. So a flailed chest is where you have basically a loose segment of ribs from an injury, typically. So it's usually 2 rib fractures involving 2 or more ribs. So now what you have is you have a segment that's loose in the chest wall, right? Because each rib has 2 fractures and it involves 2 or more ribs. So if you were to touch that segment with your hand, it would actually go in and out. Okay, you'd be able to press that segment in and out. So, for example, when they take a big breath in, that segment goes inwards. Okay, because when you take a deep breath, you have negative pressure in your chest, and that flailed chest isn't going to follow the normal expansion of the chest, so it's going to go inwards. Okay, called paradoxical breathing. Okay, so sometimes a patient with a small flailed chest, okay, well, they don't need to be intubated. We're going to give them pain medication, oxygen, and they'll be able to maintain ventilation. A patient with a large flailed chest, so a large segment, is loose. So when they take a big breath, well, that part goes inward, so they're not able to maintain oxygenation because they're not expanding that lung very well. And those patients may have hypoxemia, low O2 saturations, and they may need to be intubated because they can't maintain oxygenation. Okay? They're not able to ventilate properly because of that loose, large chest segment. What's a pulmonary contusion? A bruised lung, right? So usually from an injury or a fall, and you had a significant impact to the chest, which bruised the underlying lung. Now, if you have significant pulmonary contusions, that's going to make it hard to breathe. So if you fall off a 20-foot roof and land on your chest or your back, and you have pulmonary contusions that we can see on chest x-ray, well, that's basically fluid and blood that's leaked all into the lung. That's going to make a stiff lung. It's going to make it really hard to take a deep breath. So someone who has severe pulmonary contusions, may have to be intubated, right? Because they can't ventilate because the lungs are so stiff. A pneumothorax is a collapsed lung. If it's a simple pneumothorax, it just means that the lung has separated from the pleura and it's collapsed. So it's not being expanded with inspiration. A tension pneumothorax is when a simple pneumothorax now builds up pressure in the pleural space. That's much more severe. Okay, so a simple pneumothorax, someone might come in and say, well, I have chest pain on the side of the pneumothorax. I'm a bit short of breath, having difficulty breathing because of the pain. A tension pneumothorax, they're going to be much sicker because the pressure in the chest is moving all the contents of that side to the other side of the chest. Okay, so they're going to be acutely short of breath. They're going to be hypotensive because there's no blood coming back to the chest cavity because of all the pressure. So there's no blood coming back to the right atrium in the right ventricle. So they're going to have hyperresonant lung sounds on the side of the chest, just like a simple pneumothorax. They're going to be tachycardic, hypotensive, distended neck veins, tracheal deviation to the other side because of the pressures pushing everything to the other side. Okay, so distinguish a simple pneumothorax from a tension pneumothorax. Okay. A hemothorax is blood in the pleural fluid, blood in the pleural space. And that's typically from trauma. So you had a significant chest injury and the blood vessels in the pleura bled, or say you lacerated one of the lungs and it bled into the pleural space, and you have a hemothorax. Okay, a small hemothorax we may just ignore and just follow it. A significant hemothorax, we're going to put a chest tube in and drain it because that blood is stopping the lung from expanding. Okay, empyema is pus in the pleural space. And where does it usually come from? It usually comes from a pneumonia that started next to the pleura, and then the pneumonia infected the pleural space and caused pus collections called empyema. A pleural effusion is a collection of fluid in the pleural space. It can happen from congestive heart failure, where there's lots of fluid within the lung tissue and it starts to leak into the pleural space. Okay. So I hope that helps. I know I used 22 minutes, but I hope that helps.